Hi, everyone, and welcome. I'm Sally Guy. I'm the Director of Policy here at the Canadian Association of Social Workers. I'm very happy to be your moderator today for this webinar titled Insomnia Across the Lifespan. This is our first ever webinar on insomnia, or even on sleep, and that's reflected in today's very high turnout. So I won't talk too long before we get started. I do need to quickly acknowledge, though, that our national office is located on the unceded territory of the Algonquin people, and it's land now known to many as Ottawa, and we are very honored to be on this land. So onto the housekeeping. All of the widgets on your screen, the boxes that you see that we're talking to you in right now, they can all be resized and they can be moved around. The little icons at the bottom of your screen are where you're going to find the stuff you need, like today's slide deck for download. And you'll see throughout this presentation that our two presenters today have packaged tons of resources, further reading, links, things like that, right onto the slides. So you will want to get your hands on those. The certificate of attendance will be sent to your email automatically within a few hours after the end of the presentation. And of course, as usual, this presentation will be recorded and you can get that on demand on our website anytime beginning about tomorrow. So, structure. First, there will be the formal presentation with the question and answer period at the end, but feel free to type your questions throughout into the Q&A widget. And of course, you can always chat amongst yourselves and with me and the presenters through the chat function anytime. So now on to our speakers. First of all, we have Dr. Penny Corkum. She uses she, her pronouns. She's a registered psychologist and professor in Dalhousie University's Department of Psychology and Neuroscience. She conducts clinical research in the areas of child psychopathology, particularly ADHD, and pediatric sleep. She has a strong interest in e-health, which I'm sure many of you share. And one of her research areas is aimed at the intervention of pediatric sleep problems, with the goal to reduce the negative impact of sleep problems on child development. So attention, learning, behavior, all those things, and the functioning of the family. We also have Dr. Christopher Earle. He uses he, him pronouns. He's a psychiatrist and sleep physician. He's originally from Newfoundland. He now resides in London, Ontario, where he is a clinic psychiatrist at Western University. He's also completing a clinical fellowship in sleep disorders medicine at the London Health Sciences Centre. His clinical practice and research focus on behavioral sleep interventions and the bidirectional relationship between sleep and psychiatric disorders. And he's very interested in improving access to evidence-based insomnia interventions. So I tremble to think of the combined years of experience and education of our presenters today. We are in very good hands, and it is my great pleasure to pass it over to Dr. Corkum.
Great. Thank you very much for the nice introduction. And I have to say, I carry most of those years over Chris because he's young and I'm not. So anyways, lovely to be here and really excited that Sally invited us to give this presentation. And, you know, Chris and I are both very passionate about sleep problems across the lifespan and supporting individuals who have sleep problems and also providing education and resources to healthcare providers. And so I had never really had the opportunity to talk to a whole audience of social workers before. So this is really exciting for us. And we really appreciate the invitation and hope that we provide information that will be useful for you in your work. So in terms of objectives today, it's really to focus in on insomnia, which is a very common sleep problem across the lifespan, and look at kind of the symptoms, how it impacts individuals, and what we can do to help them sleep better. And again, we're going to take a lifespan perspective. I'm definitely more child focused, and Chris is probably more adolescent adult focused. So we're going to divide the talk along those lines. And so in terms of a outline, we're going to start with kind of Sleep 101, just to make sure we're all on the same page. I'll do that. And then Dr. Earle will talk about sleep disorders and comorbidities. And then I'll jump back online to talk about insomnia in children. And then Dr. Earle will talk about insomnia in adults. And then we're going to try to leave about 12 minutes for Q&A at the end. And so look forward to your questions. So Sleep 101, there has been some research across Canada looking at different curriculums for the development and for different healthcare providers in terms of sleep. And I'd say we could say that most healthcare providers are not really trained in the area of sleep. And I don't recall if they had looked at social work curriculum, but I would guess it would be the same as many of the other healthcare provider training where there's very little information about sleep, despite the real importance of it. So I thought I'd give a very quick crash on the necessities, and some of this you may already know, but I thought then we'd all be on the same page. And so sleep architecture just is the structure of sleep, which is really what we know through polysomnography, which measures brain waves, but also things like respiration and movement. And this is how we've learned about the structure of sleep. And as I'm sure you're aware, sleep is divided broadly into two categories. So there's non-REM and REM sleep. Non-REM sleep is really the time of low brain activity. If you were had an EEG on the person, you'd see not a lot happening at that point in terms of cortical activity. And that lessens as we get deeper into sleep. So non-REM accounts for about 50 or 75%, I should say, three-quarters of our sleep. And it's divided into 3 stages. It used to be 4, but now we have combined the 2 last stages into 1 stage. So there's N1, which is the sleep-wake transition. This is a very short period of time that we're falling asleep. We're easily aroused during this stage of sleep. And then N2 is when we enter true sleep, and our arousal from that is a little more difficult. And there's things that happen physiologically that protect us from waking up. And those seem to differ sometimes depending on the person. So how protected sleep is can be somewhat individual and also related to certain neurodevelopmental disorders as well. And then N3 is our deep sleep or slow wave sleep. And this is when we're really at our deepest sleep and have the most difficulty arousing. So it is very restorative in terms of our body function, and our body movements are preserved. So that means that we can do things like walk, like during sleepwalking. So if you see sleepwalking or other parasomnias like that, they're going to happen during non-REM sleep. REM sleep, I'm sure you're all familiar with, the dreaming sleep. It's what's kind of got us interested in sleep originally with Freud and all of people who were interested in dream analysis. So we have more information about that. It's still don't know a ton about it, but we do know that this is when our most animated dreams happen. And it accounts for about a quarter of our sleep time. And you can actually see when someone's in REM sleep, you'll see their eyes kind of little bursts of activities back and forth under our eyelids. And if you were measuring our EEG, you'd see a high level of cortical activity. It almost looked like we were awake, but our body is shut down, except for obviously important parts like respiration, but we can't move. So you wouldn't sleepwalk during REM sleep unless there was another problem. There is a disorder called REM behavior disorder that that paralysis mechanism is impaired, but typically you would not be able to move during REM sleep. And it happens somewhere after about an hour of falling asleep. And we think that the function of REM sleep is to consolidate learning and memory. And so if we wake people up during REM sleep, we see that they actually don't consolidate what they learned the day before. So some really interesting research with that. The other thing to know is that REM and non-REM sleep alternate through the nights in cycles that are a little over an hour in length. And that at the end of each cycle, which starts with a non-REM and then a REM, is a little brief arousal. And it's kind of like checking in an environment, and your brain is making sure everything is okay, and then you go back to sleep. And so you can imagine these are kind of high risk times for people to wake up more fully. So if I fall asleep in one condition and I wake up in a different condition, so let's just say I'm a baby, fall asleep in my mother's arms, and then I wake up in that little brief arousal after my REM, and I'm in a crib in a very different environment, what happens is that my whole arousal system goes up and says, okay, something's changed, we need to figure this out. So actually having those little arousals through the night is not abnormal. It's just the ability to get back to sleep is what can be problematic. You'll also notice that there is more non-REM sleep early in the sleep period and more REM sleep later in the sleep period. And this information can be really helpful to help us think about different sleep disorders. So for example, a nightmare versus a night terror. So nightmares happen during REM, so they're going to happen, most likely more in the early morning, where night terrors happen during non-REM, so they're going to happen more likely in the early part of the sleep phase. So that can help us with our diagnosing of sleep disorders. So what makes us sleep? There's two processes. The first one I think is very intuitive. The longer you're awake, the more tired you are. So there's a homeostatic kind of drive or sleep load. So if I stay up later, I'm going to be more tired. That's pretty straightforward. But there's also a circadian mechanism that is playing a role. And I think this is one that we might forget about sometimes. This is very regulated by light and then through melatonin production. And it has to line up with our sleep load. So the circadian rhythm has times where we're maximally alert and maximally tired. And so we're not going to fall asleep very easily during an alert phase. And so what happens if you think of, say, shift work, someone's very tired, they've been awake for a very long time, it's now 9 o'clock in the morning, they haven't slept yet, they have a very, very high sleep load, but their circadian clock is at the maximum of alertness, so they're not able to fall asleep. So you can see how it's so important to align these two processes up in order to be able to sleep better. We also have to recognize that sleep does change with age, and I'm just going to skip ahead here to a little graphic, which I think makes it easier to see. So this is kind of the lifespan in years. You can see that REM is quite high early on, like this is during the early infant stage. That's when all our brain connections are being laid down, so we want to have a lot of cortical activity then, and it sort of reduces over time. Non-REM reduces a little bit, but is much more stable. And you'll also see that sleep duration declines over the lifespan as well. So there are some changes, so we have to take that into consideration when we think of things like diagnosing different sleep disorders. One big question is how much sleep is needed, and there is definitely some individual variability, but there are some guidelines kind of developmentally, and the ones by the National Sleep Foundation are the ones that I think probably do the best job of providing that developmental kind of perspective. There is some debate about what components of this to use. So you'll see in the dark blue, those are the kind of the suggested amount of time. So if you look for school age, it says between 9 and 11 hours. But you'll also see there's some light blue kind of at the ends, and those are maybe ranges. And a lot of sleep researchers, at least pediatric sleep researchers, feel like that is a little too broad, and we really should stick to those dark blue components. So a school age child, 9 to 11 hours, but where do you fall in that? So that's much more of an individual decision or question. And one of the things that we can do is we can find a time where someone can satiate their sleep so that they're not tired, and then let them sleep as much as they would typically want to sleep. And that can help us identify how long they may need to sleep to feel really rested and to be functioning at their optimal level. So at this point, I'm just going to hand it over to Dr. Earl, who's going to talk about sleep disorders and comorbidities.
All righty. Hi, everybody. So I'm just going to review some of the more common sleep disorders, sleep problems, and medical problems or psychiatric problems that go along with those, and comment on some of those interactions. So obviously today we're talking about insomnia, and just to make it abundantly clear, insomnia, we as sleep physicians would call insomnia people who have difficulty falling asleep, staying asleep, or attaining sufficient sleep despite an adequate opportunity and adequate circumstances for sleep. People who have inadequate opportunity or inadequate circumstances for sleep are in a bit of a different situation. And most notably, insomnia is associated with distress around the amount of sleep or daytime impairment. It's important to acknowledge other sleep problems, or at least be familiar with what they look like, because sometimes patients will come to clinic or speak to their healthcare provider, and they will say that they have insomnia, but when you hear them talk about the exact problem they have with their sleep, you realize it's not necessarily insomnia. These other sleep problems can complicate the treatment of insomnia. They can co-occur with insomnia, and they can actually sometimes, change the treatments that we use for insomnia. because of interactions with medications and other health problems. So I think the first thing to recognize is when somebody has what I would call decreased sleep opportunity. So this is, I think of this as somebody who's burning the candle on both ends. You can think of a student who's up late studying and then up early for class. They can often feel like they're not getting a good amount of sleep, but it's not because they can't fall asleep. It's because they simply don't have time. And if you're working with people in stressful life circumstances, like new parents, single parents, caregivers of elderly individuals, it's very common to see this as a presenting complaint. And people will often ask for sleeping pills because they have, 5 hours to sleep and they want to go to bed and knock out immediately and then, wake back up and start right back with their busy day. And unfortunately, sleep doesn't really work like that. And our body does need some time to wind down. There are people kind of like Dr. Corkum just mentioned who are characteristic shorter sleepers. This tends to be a bit more of a lifelong tendency, but it can develop with increasing age. And the thing to note in short sleepers is they don't have that daytime dysfunction or impairment. So these are people can often be troubled by the fact that they're not sleeping, 8 hours, but they may not need 8 hours. It might, I can often think of elderly individuals who are very concerned that they're not sleeping from, after supper until the morning, but they don't need that much sleep anymore necessarily. And you kind of have to look and see if they have that daytime dysfunction. And, I remind people that 30% of the population sleeps more than 9 hours and 30% sleeps, as less than 7 hours. So, that target 7 to 9 hours that we tell everybody or we see on graphs might not apply to an individual necessarily. And like Dr. Corkum said, the times of sleep does vary somewhat with age. I say approximately every decade, our sleep need changes through the lifespan. There are also circadian rhythm disorders. So these are people whose major sleep interval occurs at a different time than the conventional normal. So it can be delayed. I often think of that as university students or people in their teenage years who, are very much night owls, go to bed at 3 or 4 in the morning and want to sleep into the afternoon. Less common is people with advanced sleep phase syndrome, or even non-24-hour rhythm disorders, which you'll often see in people with severe dementia or severe developmental concerns. And really, it's about sleeping at a conventional time. And when these people can sleep on their preferred schedule, they sleep quite well and don't experience any other problems. And again, it's a situation where a little bit of education can change someone's perception of whether or not something's a problem. When we think of more intrinsic sleep disorders, things like restless leg syndrome come to mind. So people who find that in the evening or when they're at rest, they get this unpleasant feeling in their legs that's exacerbated by things like caffeine and alcohol. We manage that predominantly with lifestyle modification, but there are supplements and medications that can help. There are other sleep-related movement disorders, and I think it's important to know as social workers that these problems like abnormal movements during sleep, grinding teeth during sleep, are often associated with stress, psychiatric medication, substance use, sleep deprivation, or untreated sleep disorders like sleep apnea. Sleep apnea is probably the thing sleep physicians are busy with the most because there's a lot of it around, which is a problem with breathing during sleep where our muscles in our neck and our throat relax, and they can cause blockages in breathing and in obstructive sleep apnea and lead to unnecessary awakenings during the night, which often leaves people feeling tired during the day and also can be a risk factor for other medical complications. And that would be diagnosed either with a home sleep test or in a sleep lab. And oftentimes, if you hear people say that they're bad snorers and they're waking up feeling non-restored, it would be reasonable to suggest they see their physician or go to a sleep lab for a sleep test. There are many other sleep problems. Some you probably experience yourselves as social workers, like shift work sleep problem, which is a difficulty adjusting to different shift schedules, or even seeing your patients like nightmare disorder, and especially sleep problems as core symptoms of other disorders like in PTSD, depression, and dementia. We can see nightmares, changes in the sleep schedule, and like I said, that non-24-hour rhythm surrounding sleep. When we think of comorbid conditions, it's important to know that insomnia doesn't come comorbid with many medical illnesses and mental disorders. And we do diagnose insomnia separately when the symptoms of insomnia are persistent and prominent. So we know many people going through cancer treatment on steroids can have disruption in their sleep, but when the insomnia itself seems to be self-sustaining and in there during times when people are not necessarily getting their chemotherapy regimen, we wouldn't diagnose insomnia separately. This is more just for reference, but we do see, some disorders like chronic pain. A third of people with insomnia have that. 80% of people with depression will experience insomnia, and up to 50% of people with obstructive sleep apnea. So we see it across medical, mental, and sleep disorders. Comorbid mental illness has a particularly strong bidirectional relationship with insomnia. 50% of people with insomnia will have a comorbid mental illness, and up to 80% of psychiatric patients have some diagnosable sleep disorder. So sleep health is very important for people with mental illness. And I'm just going to pass things back to Penny now to talk a little bit about, Dr. Corkum, to talk about sleep in children.
Excellent. I assume people can hear me unless I hear different. I'm going to just go ahead. So we're going to focus on sleep in children now. And I thought I would start with just a little bit of a snapshot, I guess, of how kids are sleeping in Canada. And not great. And this is pre-COVID. And so these are statistics that were pulled together by Participation. And you can see generally about a third of Canadian kids are not falling asleep, have trouble staying asleep, are not waking up easily, are feeling tired during the day. And what they have linked this to is that kids may not be getting enough physical activity. And so they have a report out called "Are Canadian Kids Too Tired to Move?" And I think it's a really important question, where they say, if children are not getting enough physical activity and then they're not tired and then they don't sleep well, then they don't have the energy to be active. So we get this vicious cycle happening. I think that's one of the components. I think there's many components. That's one of them. They did come up with some really amazing guidelines that look at movement behavior. So vigorous movement, more light, gentle movement, reduction in sedentary behaviors. And for the first time ever, they included sleep as a movement behavior. And Canada took a lead in these guidelines, and we're the first country to include sleep. And now this is happening around the world. So I think sleep is being recognized as a really critical component to healthy behavior and just being well, cognitively, mentally, physically. So we can talk a little bit about the causes of poor sleep. And I think it's best to think of sleep from a biopsychosocial perspective. So there's definitely influences at each of those levels. So biologically, for example, there seems to be a pretty big genetic component in our circadian preference. So whether we're owls like night people or larks morning people. So that seems to be some genetic kind of contributions. When we think of psychological, we can think of kind of some of the learning that's happened in families and how they might think about and behave towards sleep. And then some of the social components, like the social cultural components around sleep practices. And we also want to think of the 3 Ps. So different factors may be predisposing a child, precipitating a child's sleep problem, and perpetuating it. So maybe, for example, they have a different circadian preference than their parents, so that might predispose them to some sleep challenges. And then there might have been a precipitating event, like a health issue where the parent co-slept with the child because they were worried about the child. And then perpetuating that might be some sleep practices. And so we would have to think about all of those components when developing and implementing interventions. So poor sleep can be because of a sleep disorder like Chris just went through, which is about maybe a third of kids, maybe a bit more adults have like a diagnosable sleep disorder, which is, I think, really high. And insomnia is by far the most common of those sleep disorders. It can also just have sleep problems, so more related to lifestyle factors, and we're going to talk a bit about those later, but like electronics and activity. And sometimes this lifestyle factors can really make you feel like you have jet lag. It's like going to Paris and back on the weekend and being, ready to go to school or go to work Monday mornings, just not possible to feel good. And that can also result in some sleep debt over time, which has a lot of negative impacts. So in terms of prevalence of insomnia and different sleep disorders, again, you can see insomnia is about 20 to 30% of children. And children who have neurodevelopmental disorders like ADHD or autism spectrum disorder or mental health disorders like anxiety and depression will have very high rates of insomnia. Dr. Earl already talked about how we define insomnia, and I just wanted to highlight that for children, we're often going on what their parents report and not the child's perception of feeling tired. So it's a little different than in adults, but we use some of the same criteria in terms of that it has to be chronic and frequent and can't be explained by some other factors. And it can also, the kind of type of insomnia or what is driving that insomnia can differ based on developmental stage. So in children, we often see sleep onset problems. So they expect certain conditions to be in place when they're going to sleep and they aren't there when they wake up, and that can cause some difficulties, some bedtime resistance and difficulties with limit setting. As we move into the adolescence years, we see a lot of poor sleep practices like using electronics at nighttime, but also there is truly a biological shift that happens in our circadian clock that delays us. So they actually want to go to sleep later, biologically want to go to sleep later. And of course, school still starts at the same time and everything else still happens at the same time. So that can put them out of sync and cause some delayed sleep phase problems. And then as we move into adults, we can see some of the physiological, some of the anxiety and worry and catastrophizing about not being able to sleep and worrying about that can also perpetuate the insomnia. And you can see from the prevalence of insomnia across the lifespan that there's some peak times when there's more risk. So during infancy and during toddler years, and this is when they're consolidating their sleep, and a lot of those sleep associations are important at that time. And also again in adolescence, during puberty, when we have that biological shift to a later time for our circadian preference. And what about impact? Well, it has impact across all levels. So in the child, there's some really good research, some of it that came out of my research lab, looking at the impact of sleep restriction. Like if we take children who are good sleepers and we take sleep away. So we did this for 7 nights in a row. We took 1 hour sleep away from children, and we could identify on objective measures after just only 7 days of 1 hour less a day, impacts on their cognition, their memory, their learning, their focus, their emotional regulation, their level of anxiety. And that's only after 7 days. So can you imagine if you're not sleeping well for a year, 2 years, 3 years, what that could do? We do know that it's associated with increased mental health problems, as Dr. Earl talked about, as well as even some physical health problems like metabolic difficulties, and then of course quality of life overall. So it has a pretty big impact on the child who's experiencing the sleep problem, but also on the family. So parents of children with sleep problems tend to have poorer sleep themselves, and their siblings may have poorer sleep. Tends to be related to increased parental stress and increased rates of parental mental health problems, and also the use of more negative parenting practices. And I think that's pretty intuitive. Like probably all of us have been tired, and all of us know what it feels like to be tired. And if you're trying to handle a situation with your child, I think we're more likely to act negatively in that situation. So it's really important for the parent to sleep well as well. And of course, at school, kids who are tired are not ready for learning and have more dysregulated behavior. So that can really have an impact on the school and also in the community in terms of work and meeting other community responsibilities. As Dr. Earl already mentioned, there's a link between sleep and mental health. And what I find probably one of the most fascinating findings in the research is that sleep problems can actually precede and predict mental health disorders. So sometimes in certain situations, we will see sleep problems or sleep becoming dysregulated before we'll see depression or maybe a bipolar manic episodes. So it can help. If we can intervene, then we might be able to avoid some of the other problems. We also know that if we treat sleep problems, we can have an impact on mental health symptoms. But if we treat mental health symptoms, we don't tend to impact sleep. So it is important to include sleep as part of the treatment program. And also, if we improve sleep, we improve the treatments for the mental health problems. So for example, if a child had a language disorder and a sleep problem, they're going to respond much better to speech and language therapy if they're sleeping well. So you can see why it's such a priority area to ensure that people are sleeping well. I also thought I'd share a little bit about sleep and adverse childhood experiences, and there's a quite robust body of literature that shows that there's a strong connection with ACEs and insomnia and other sleep problems during adolescence and adulthood, and also that there is this kind of concurrent association with increased nightmares and also changes in sleep physiology, especially at that stage 2 when we go into true sleep, with sleep spindles changing. And that obviously, I think this would be intuitive, the more ACEs, the more likely to have sleep disturbances. And this is even after we adjust for things like anxiety and depression, which are common in those situations. And we have found in the research that sleep can mediate the relationship between ACE and poor mental health outcomes. So there could be a real opportunity here for intervention that could have pretty pronounced and positive impacts. I really like this model. It just was published in 2020, so fairly recently, Roberge and Bryan. And basically what it's saying is that the precipitating event, the traumatic event, can result in kind of this emotional dysregulation at the emotion and brain level that then can result in some changes in sleep. So changes in REM sleep, in the stability of sleep, more sleep fragmentation, and then the individual can start to use strategies that may, at one hand, seem like they're helpful, but actually are not. So drinking alcohol to go to sleep, for example, and that could perpetuate the sleep problem and then ultimately lead into a chronic insomnia related to that trauma. So this is just an important model to think about in terms of how you might intervene. So I have a little bit of time to go through treatment of insomnia. Of course, this is a short version. So I like to think about it in this way, like a stepped approach. And so there's different levels, and we should really go through them in the order from bottom up. Unfortunately, I'll just kind of walk through them very quickly. So unfortunately, the state of affairs is that most times people with insomnia are treated with medication, but really that should not be the first line of treatment. We should start at the bottom of this pyramid and work our way up. And I'm going to just go through each of those very quickly. Oh, I guess I had one more thing to say in this slide, just was that very few kids receive evidence-based treatment, which would be from bottom up, and particularly kids who have mental health problems and neurodevelopmental disorders. Often it goes right to medication. So let's go through each of the steps. So first is addressing other concerns. So we just have to deal with things that may be interfering with sleep. So, excuse me, Dr. Earle had given a good example about sleep apnea. And so if that was a problem, we need to deal with that before we, address the insomnia. I'm sorry, I'm getting over a cold. Just 1 second. Always when you're online, it tickles. Okay. I think I'm going to have to step away.
I think after however many years through a respiratory pandemic, we're all
thank you.
Fairly sympathetic. I'm used to these things.
Yeah, I had it about a month ago, and the cough is lingering. Anyways, thank you, and sorry about that. Hopefully you can cut that out of the video. So the second level is psychoeducation, so teaching about sleep, and kind of going through everything we just went through, lots of times there can be a misalignment with expectations. So a parent may think the child needs to sleep more or less than they actually have to sleep. And that can set up some perpetuating situations where the child develops sleep difficulties because of that, or there can be underlying problems. They may not feel safe. There could be medication issues. And so we want to just make sure that people understand sleep, how it works. So for example, I remember when I was a new mother, and this is before I started studying sleep, and my son didn't sleep well, and I tried to keep him awake because I wanted to increase his sleep pressure. And of course, I wasn't thinking about that circadian phase, and so it didn't work at all. And then I learned afterwards what I had done wrong. So make sure that the practices are good, and then we want to move into healthy sleep practices. This used to be called sleep hygiene once upon a time, but we're trying to change the label just because it's kind of a negative label. And so there's lots of things we can do to try to make the individual more likely to sleep well. And I always had a hard time remembering all the components. So I gave my students a task to help develop a mnemonic to help me remember, and they came up with ABCs of sleeping, which works exceptionally well. We have done lots of research on this using this mnemonic and looking at the evidence for it, as well as developed a mobile app that assesses the ABCs of sleeping and provides tips for parents to help their children sleep better. So I'm just going to go through each of the components. And so these are things I really feel like you could help families with to help with those healthy sleep practices. And so first is age-appropriate bedtimes, wake times, and nap times with consistency. And so that's really important. We already talked about that. Sleep needs change across development, so we need to know what those are. We really need to maintain that consistent schedule. And the recommendation is no more than like a half-hour difference between weekends and weekdays in terms of bedtimes, or else it can get hard to go to sleep at the right time. With adolescents, you can imagine that can be quite challenging. Some people might say up to an hour, but again, you really want to maintain those consistent bedtimes. Also, a lot of people don't think about the wake time, but the wake time actually drives the bedtime. So often scheduling the wake time is more important than scheduling the bedtime. If you keep to that wake time, you're eventually going to end up being tired at the right time. And so really think about that wake time and what works for that individual. The next component of the ABCs of sleeping is the S there. It's schedules and routines. And again, it's not just about bedtimes and wake times, although those are critical. It's about the whole 24-hour cycle. I think we're really recognizing, sleep is not different. It's, sleep and wake are together, and we have to think of them together. And so our bodies want consistency throughout the 24-hour cycle. And the more consistent we are throughout our day, the more likely we're going to sleep better. We might want to use things like visual schedules with kids. For kids who can read, we can use the one in the middle, the one on the left for kids who might be pre-reading stages. And for children who might have some cognitive impairments, we can even use really concrete examples of the kind of visual schedule. We also have to think about the location. And so while the pictures at the top are really exciting and fun and, maybe good for a playroom, they're not really good for sleeping. We need to sleep in an environment that's not overly stimulating, that's comfortable, your own bedroom or your own bed, at least when possible. We want to reserve it for sleeping. So no like timeouts in bed or playing on your bed. If there is nowhere else, because someone lives in a small area, you have to develop some routines to make it into a sleep environment. So maybe taking all the toys and putting them all to bed somewhere else and then clearing the bed off. So you really want that stimulus to say, this is bed, this is sleep, this is where you sleep. And so you want to make your bed only for sleep, or with adults, we can also have sex in there. That's okay. But for kids, just sleep. And you want it to be dark. So, can you put dark blinds in there? Can you make it dark for sleep? But also you want it bright in the morning. You want to start the day off with bright, kickstart our circadian system, and you want it to be cool and quiet. And then the E is for electronics. And so I think, this is, everybody's talking about this, but it's important not to use electronics at bedtime. A lot of times people talk about the light, which is important, but it's also the stimulation. So we, we're going to be doing things on our computers and iPads, etc., that are stimulating, playing video games or watching things, or maybe even disturbing, like watching the news, and that's not conducive to sleep. You need to get in a relaxation state to sleep. So the rule is no electronics in the bedroom and not to use 1 hour prior to bedtime. And then, of course, we, like I talked about, participation, exercise, and diet are critical for healthy living, and it does impact our sleep. And so getting daily physical activity, following the participation guidelines and the Canadian food guidelines as well. Not having caffeine is important, especially before bed, and not going to bed hungry or too full. So you need to kind of find a nice balance there. And then the PIN stands for positivity and relaxation, independence and sleeping, and needs met during the day. So need to have like a positive attitude towards sleep. It shouldn't be a time of stress. It should be a time of moving into darker environments and calmer environments. Should be relaxing and calming. Sometimes may need to do some relaxation therapy in order to get to that state. It is most helpful if someone can settle on their own to sleep, so that when they wake up in the middle of the night, they also can settle back. So what I find really interesting is when I treat sleep problems, I treat the initial sleep problem, and then the rest treats itself, which is really exciting. So once the child has learned how to fall asleep at bedtime, then they can use those strategies to fall asleep in the nighttime when they wake up. So learning to settle on their own is a big piece of sleep intervention. And then having all your physical and emotional needs met during the day. So we do need to talk about our experiences, if we're having a hard time at school, but we don't want to do that like at bedtime. I remember with my son, he always wanted to tell me all the bad things when he laid in bed. And so I had to make a time during the day that was to talk about those things. And we had like that he could say them, and I'd write it down and park it and talk about it the next day during our time, which was at supper time or just after supper. So we want to make that bedtime comfortable. We want to make sure that we've met all those needs. And it can be really hard, especially with parents working and not much time in the day, and kids have needs for attention and affection. So how do we get that all in before the bedtime? And then, of course, if you do all these things, it should equal some pretty great sleep. And while they may seem simple, they're not simple to implement, and they can be challenging. And the research does show that these in themselves can be quite impactful for children's sleep. I'm not going to spend very much time on the rest, but just to say that if that doesn't work, then we need to move into specific behavioral interventions. And I would suggest that these are often best led by someone who's trained in sleep medicine or in sleep. And we know that these work through a large body of research on children, with most studies showing them to be effective for the majority of children. And they seem to be, they have long-term impacts. And we don't have a big amount of research on children with neurodevelopmental disorders or mental health problems, or children who have trauma or adverse events. But what research is out there is that it does seem to work with them as well. And so there's lots of things here that I can't go over, but basically it's using learning theory and behavioral principles, and as kids get older, cognitive behavioral theory to help them sleep better. And I think Dr. Earl will talk a bit about those in his presentation. And then medication is pretty simple and short for children. There are no approved medications for pediatric insomnia. End of story. Any medication that's going to be used for pediatric insomnia is off-label. It's never been evaluated in children. We do have to think about the timing of other medications. So if we're treating, say, ADHD symptoms, we have to think about when we're giving those so that it doesn't interfere with sleep. And we also always have to keep in mind that the child is often not the one communicating about their sleep problem, but it's the parent. So we need to take that into consideration. And then I'll just end the kind of information part with talking a little bit about trauma-informed sleep intervention. And definitely there's a little bit of research about that intervention, and it's quite interesting. It shows that if people sleep after a trauma, they actually have reduced negative impacts of that trauma. So that's very fascinating to me. And also that people who get back to good sleeping schedules kind of early have less risk of developing PTSD, which I also find very interesting. So sleep can have a mediating impact on outcomes, which I think is important to recognize. And so what do we do different? Well, the research says we can do pretty well the same work. So we follow those ABCs of sleeping. We do good sleep education. We want to maybe work a little more on that relaxation response. So we might want to include more relaxation training, because that might be harder because of the hyperarousal that's associated with trauma. And also think a little more about the safety of that sleeping environment. You have to feel safe to fall asleep. So that will be really important. And I did include a couple of links that provides a bit more information. And I am going to end just with a little bit about my research lab and some opportunities that exist within that. So first of all, just acknowledge my research funding and all of the lovely students and staff that work for me. And what we've been doing over the last decade, so this all started for me way before COVID, was wanting to develop a wraparound evidence-based virtual care for children with sleep problems. So we have an e-health intervention called Better Nights, Better Days. Really cool intervention. I don't have time to go into it, but it is very tailored, and it's for parents so that they learn the skills to help their children sleep better. And we have a version for typically developing children and children with neurodevelopmental disorders. And we're soon going to develop or release a version for parents of children with epilepsy. And we also have that mobile app I was talking to you about, focusing on healthy sleep practices. And this is for parents to use to help their children sleep better. We have a program for adolescents and young adults that they can use, an online program. We have a curriculum for teachers so they can teach their students about healthy sleep and why it's important, and help them establish healthy sleep practices. And we are just releasing, as of yesterday, so it's really exciting, a program for healthcare providers to learn more about pediatric insomnia, and so that they can use that in their practice. And then we have a virtual hub that we're developing that's going to link all of this together. And so we have 3 projects open for participation right now. One is Better Nights, Better Days, NDD. So this is for parents of children with any neurodevelopmental disorder. So Down syndrome, ASD, ADHD, and it's an implementation study, so it's exciting. We've already ran the randomized control trial, so we're just looking at how we can reach people, how we can engage them, and how they do with the program. And so they all get access to the intervention, and they just have to go to that website, ndd.betternightsbetterdays.ca, and they can complete a eligibility questionnaire. We also are running a randomized control trial for the app, the ABCs of Sleeping app. And again, this is for children ages 6 to 12, their parents. And it's kind of a cool program. They will be randomized either to the app or have to wait a month to get the app, and then have to collect give us some data about how it worked. And as of yesterday, we just got ethics approval, so this will be up and running very, very shortly. It's a module for healthcare providers to learn more about sleep. It's 4 sessions, about an hour a session. It's all virtual, and we need social workers, so hopefully some of you might be interested in being part of that. And then if you're just interested in sleep generally, you can follow us on one of these social media outlets, and we always post any new studies there. And then I'm not going to go through all the resources, but I did provide some websites and some books and some other types of resources for children and for children with neurodevelopmental disorders. And with that, I am going to hand it over to Dr. Earle, and I will spend a little time looking at the chat and answering any questions. I saw some came up, but I didn't have time to stop. So, and I did go over a few minutes. I'm very sorry. So we might run a little late. And I apologize for that. Coughing fit in the middle.
I was just thinking we were doing well for time. Hi, everybody, again. So now I'm going to focus a little bit on insomnia in adults. And I will say some of these slides I've included more for your information and review after, because I know some of this is not necessarily applicable directly to your practices, but if it is, the resources are there. So I'm going to go through the presentation of adult insomnia, its impacts, briefly, some tools that I think are very helpful for assessing sleep in adults, and then some information. Most of my time I'll spend on what treatments exist for adult sleep problems and medications as well. Lots and lots of resources. So again, insomnia, the clinical criteria are right here, which we've reviewed previously. Difficulty falling, staying asleep, or waking up too early, causing distress and impairment and dissatisfaction with sleep. We distinguish between acute, meaning short-term, and chronic, long-term insomnia, and that crossover is we kind of draw the line at about 3 months. So if you've been having these symptoms at minimum 3 nights a week for at least 3 months, we would call it chronic insomnia or insomnia disorder, as opposed to shorter periods of time, which would be more of an acute insomnia process. And that does make a difference in how we manage these problems, which is, I think it's important to highlight. If you look at the landscape right now in Canada, especially over COVID, where there's been increased rates of insomnia symptoms, up to a third of the population experiences some insomnia symptoms on a brief or limited basis. Probably closer to 10 or 15% of the Canadian population experiences chronic insomnia symptoms. We know it's more common in women, in older adults, in people with medical or mental conditions, and in individuals with lower socioeconomic status. Insomnia does have a fairly large burden of illness. Like we've mentioned, there are increased risks of depression and suicidality, and in some conditions, suicide completion. We do actually now, this is more recent data, see increased cardiometabolic risks. We know that there's occupational impacts, both in absenteeism, so missing work, and presenteeism, being there and not necessarily fulfilling every aspect of your role. As well as it can confound levels of disability from other conditions. We see increased healthcare service use, and we even see things like increased risk of motor vehicle collisions in people with sleep deprivation. These are some slides on how insomnia develops, and I need to give thanks to my former psychotherapy supervisor, Dr. Sheila Garland, who shared these with me when I was going through my training. When we look at insomnia, we know, this is kind of a framework we used to discuss it called the 4P model. You can think of this as being an arbitrary threshold. And if all the factors combined lead you to be above this line, you would have sleep problems or insomnia. And if you're below it, you probably wouldn't. So everybody has an underlying amount of predisposing risk, which is present in all stages of illness. And that includes things like I mentioned, different risk factors for insomnia, family history, trait anxiety, and medical or psychiatric conditions, and especially trauma, I think can play a big role in this, both as a predisposing and a precipitating factor. On top of that predisposing risk, in the acute sense of insomnia, so when sleep disruption develops, there's most often a precipitating factor. So that could be a medical illness, a psychiatric illness, or even a positive life change like a new job or a new baby. And if we look at how that impacts our sleep, in the short term, so over weeks, it often leads to disruption, but I like to think of the fact, of time healing wounds. Gradually over time, if you have a broken arm that's disrupting your sleep, it's going to gradually get better and have a less and less impact over time, that specific thing itself. And like I said, 3/4 of people actually can identify one of those precipitating events. The unfortunate thing is that in the short term, if someone's sleep has been disrupted for a number of weeks, they're going to start developing habits and behaviors that are going to, in the short term, help their sleep, but in the long term, potentially cause more problems and add in as perpetuating factors in their insomnia. This is things like spending more time in bed, trying to catch up on sleep, napping, or even starting to take sleeping pills. And over time, that adds on to, the precipitating and predisposing factors continue insomnia. And one most notable factor, especially if we look at people with chronic, so insomnia lasting months and years, is something we call conditioned arousal, which is essentially this sense where a lot of people with insomnia have, where when they get into bed, they feel more awake than they even were when they were sitting up in their living room. And I threw in a quote from a patient I had just last week who said, "It doesn't matter how tired or how hard I try to sleep. As soon as I go to bed, my mind starts racing and I just can't shut it off." And that is a perfect description of this conditioned arousal phenomena. And we actually look at the timeline of insomnia over time. Acute insomnia is very much caused by the precipitating event. In that short-term conversion period, we kind of see both factors being at play. But in the long-term or chronic insomnia patients, we actually see that the perpetuating factors are the majority of the reason they still have insomnia. And that's why we treat insomnia not necessarily with just medical treatment of the underlying problem, but also with cognitive behavioral treatment like CBT for insomnia. I'm just trying to advance the slides here. Oh, there we go. So I'm just going to show some tools I use for assessing insomnia in adults. I know oftentimes it's quite apparent or being assessed by another individual. These are all the components that I assess when I'm doing a clinical assessment for insomnia, but recognizing the broad spectrum of things you're assessing in your clients as social workers, I don't necessarily think it's realistic to focus on every single one of these points in every single patient. So I have included some tips for what I would think would be a more practical or focused assessment for someone with a sleep complaint. And that would be reviewing their sleep schedule, looking at areas of daytime dysfunction, looking at unhealthy sleep behaviors and especially substance use as well, as it can often be implicated in short-term sleep difficulties. So all of these factors of a sleep schedule are actually covered if you were to get a sleep diary. And I find this is often much more realistic, especially for patients who can follow those instructions, because you're not going to get them focusing on just the worst night. You're going to see what the last 7 nights live with. And I will say that every patient in my insomnia clinic completes and returns one of these diaries for basically every appointment. And sometimes that's with the help of a parent or a caregiver. And guidelines recommend the use of sleep diaries in assessing insomnia. When we look at daytime symptoms, I focus on, what are the impacts of the insomnia on their daytime mood, energy, concentration, function. But I also assess, and this gets into a lot of the ABCs of sleeping things that Dr. Corkum mentioned, their level of physical activity, their level of nutrition, their level of daytime light exposure, and because I know how big an impact those things do have on how the night goes. I think it's particularly important to assess for these easy fixes that I call. So things about the sleep environment that, we can directly modify and they can make big differences. So things like direct impacts on sleep, like acid reflux or hunger, or if people are going and taking tons of pre-workout an hour before they're hoping to go to bed because they're doing a late night workout after their kids have gone to sleep, that stuff can have big impacts on sleep, and it ends up being, more or less easy fixes. I also spend some time focusing on substances, their amount of use and their timing. Alcohol is probably the most commonly abused substance for sleep. I call it the best and worst sleeping pill. It definitely helps people fall asleep, but it leads to more awakenings later in the night. Caffeine use, especially after midday, caffeine lasts in our body 6 to 12 hours, depending on the person. So coffee after lunch can and will impact your ability to sleep, especially if you have a sleep problem. And as well, nicotine is a stimulant. So people who are smoking a lot late at night, especially if they're stressed. Some useful scales or measures. So the consensus sleep diary, which is the one I had the picture of a little while ago. The Are You Sated questionnaire assesses multiple avenues of sleep health. These are scales I use in my practice, and is more here just for reference. And a sleep apnea risk score is particularly useful as well if you want to find those people who should be going to a sleep lab and getting a sleep test. When I think of common approaches to managing insomnia, like when I talk to my colleagues in family medicine or even in psychiatry about this, they usually say one of two things. It's either a sleep hygiene handout or a fistful of pills. And the problem with that is neither of these approaches are particularly evidence-informed or particularly likely to improve chronic insomnia in the long term. So I really do think we can do better for our clients and our patients than this sort of thing. A word on sleeping medications before we move on to the other options. Unlike in mental disorders like depression or psychosis, we haven't identified a specific chemical imbalance in the brain in insomnia. Most sleep physicians, like myself, prescribe few, if any, sleeping pills for the treatment of chronic insomnia. I honestly can't remember the last patient I gave a sleeping pill for insomnia. Sedative hypnotic medications have limited role in the management of chronic insomnia, and they really have no long-term benefits. There can be some short-term benefits or some benefits for use in acute insomnia to prevent that conversion to long-term insomnia, but that should be assessed on a patient-by-patient basis, and I certainly don't endorse sleeping pills for everybody with acute insomnia. There's a number of different sleep medications, and they include prescription medications and non-prescription medications. Most commonly, the benzodiazepine receptor agonists. So that would be things that end in PAM, or the Z drugs like Zopiclone, Zolpidem. Oftentimes, prescribers are giving antidepressants and antipsychotics with sedating side effects to help induce sleep, even though those medications are not approved or endorsed for the use for sleep. And there's also a number of non-prescription agents. So in Canada, melatonin, and as well cannabis. Melatonin does have some evidence for some sleep problems. There's not a lot of evidence for general adult insomnia. There is some evidence for its use in children with neurodevelopmental disorders. That being said, like Dr. Corkum mentioned, it's considered to be a later stage thing that we should do after behavioral interventions, not as a first step change. And specifically, cannabis is one I get a lot of questions about, and I have seen some questions in the chat there about. The real problem, and this is from a website called My Sleep Well, which is an excellent sleep health resource. The real problem with sleeping pills for insomnia is that people develop tolerance of the drug over time, and it leads to loss of that beneficial effect. So you'll start with insomnia, you'll start using a sleeping pill. It will improve your sleep temporarily, but nightly use becomes associated with gradual loss of effect. So people are not finding it as sedating, and then they're on a dose increase. And then, the dose increase stops working, and it keeps adding and adding. And if at any point the sleeping pills are stopped in a cold turkey fashion, people have with this horrible withdrawal syndrome where their sleep is even worse than it was before, and it just becomes a self-perpetuating cycle. If we actually look at the evidence for these drugs, these are for this is a meta-analysis looking at the data for all of the Z drugs, so like the non-benzodiazepine hypnotics. When patients actually reported it themselves, there was a 7-minute faster improvement in sleep compared to placebo on these drugs. And when we actually measure in a sleep lab, there was only a 14-minute benefit over a placebo. Now, I will say placebos do have benefit in these conditions. We see a benefit of about a half hour from a placebo. So it's making the difference between, a half hour earlier sleep onset on a sugar pill versus, 45 minutes on one of these drugs. And the benefits are not really worth the risks associated with their long-term use, is the prevailing medical opinion of them at the time, especially chronically. Many users of cannabis report benefits for sleep. Research from the studies that exist, and I will say that I have yet to see a large, well-controlled study. They all seem to be small, unrandomized studies, show inconsistent evidence of benefits and risk, and often they're not focusing on sleep as the primary problem. It's cannabis for something else, and they're reporting sleep as a secondary outcome. People do report themselves falling asleep more easily, less sleep disturbance, and better sleep quality. We know that there's less dreaming sleep. So the benefits of dreaming sleep, you might not be getting those on a cannabis-induced sleep. And we also see, like in all sleeping medications, disrupted sleep after the discontinuation of cannabis. And really, overall, those high-quality studies are lacking. And if I was going to make a list of, benefits and risks, some people report improved sleep, but that's not shown in the evidence to ring true. We know that there's risk of respiratory irritation or lung damage in smoked forms. The withdrawal symptoms still exist. And we specifically, and I will caution this as a psychiatrist, know that there's impaired brain development and an increased risk of psychotic disorders independently associated with cannabis use in users under age 25. Furthermore, I think there's a whole other problem about inconsistent strength and quality of these products that people are acquiring, especially when from unregistered vendors. So I really think the cons outweigh the pros for cannabis and sleep. That being said, I have seen lots of people using it for sleep. My question I often ask is, well, if it's fixing your sleep entirely, why are you in my clinic talking about your sleep difficulties? If it's fixing your problem, you shouldn't have any more complaints, it would be my logic. Just clicking. Okay, sorry, there was just a little bit of lag. Did I miss a slide there? So yeah, if I was going to summarize sleep medications and substances, they all come with side effects. No hypnotic agent has been shown to be entirely useful for reversing chronic insomnia. Some medications can be helpful in the short term, and sleep medication is not a long-term answer for chronic insomnia. Talking about CBT for insomnia, it's the first line treatment for chronic insomnia. It's a form of therapy that combines cognitive and behavioral strategies to address problem thoughts and habits that sustain chronic insomnia. Typically, CBTI goes on for 4 to 8 weeks, and it can be delivered in multiple formats. It has a robust evidence base showing it affects it impacts basically all the things we want to improve in sleep: the time to fall asleep, time awake in the middle of the night, total percentage of the night spent asleep, the severity of insomnia, and the sleep quality. And the benefits go, much longer than the framework of treatment. We see benefits sustained at even 5 or 10 years. And we see benefits beyond sleep, much like Dr. Corkum alluded to. When we treat the sleep, we see the anxiety improve. When we treat the sleep, we see the depression improve. When we treat the sleep, we see the chronic pain even improve. Multiple guidelines endorse CBT for insomnia as the first-line treatment for chronic insomnia. And like I said, it's a multi-component therapy involving sleep restriction, stimulus control, relaxation training, cognitive therapy, and sleep hygiene, which sounds like a lot to do, but it actually moves quite quickly in the therapy. Basically, we conceptualize insomnia in this vicious cycle where unhelpful behaviors like watching the clock can lead to unhelpful thinking, like worrying about poor sleep or the consequences of sleep, which can cause unhelpful emotions and stress, which in turn leads to more feeling awake and alert, and more of these unhelpful thinking and behaviors. And we specifically address those by addressing negative thoughts with cognitive techniques and negative behaviors with behavioral techniques. Just to go over it quickly, we use sleep diaries to gauge the amount of sleep patients are currently getting. We use a method called sleep restriction to match their time in bed to the current amount of sleep that they're getting, with the goal of improving that homeostatic sleep drive. We also give a strict bedtime schedule to get people consistently up at a regular wake time. So someone's sleep might initially look like them going to bed and taking several hours to fall asleep and being very broken. But, this 5 hours of sleep here is being spread over 8 hours in bed, versus we say, if you're sleeping 5 hours, spend about 5.5 in bed, and you'll sleep in a much more consolidated sense. And then gradually over the following weeks of therapy, we slowly increase the time in bed so that they can expand the sleep window in a way that's been shown to work and improve their overall sleep. We use stimulus control, which are some of those instructions that Dr. Corkum mentioned, like only being in bed for sleep and in adults for sex as well. And really waiting until feeling sleepy to go to bed. And if not able to sleep, getting out of bed during the middle of the night and getting up at the same time every morning. And we try and limit napping if possible in adults. Those 2 steps alone show 80% of the observed benefit of CBT for insomnia. But we also add in relaxation training and mindfulness techniques, some cognitive therapies techniques, so some thoughts, simple thought records, unpacking worries about sleep, and helping people come up with balanced thoughts around sleep that they can use in times of worry or anxiety. We also do scheduled worry times, so they're going to unpack those worries earlier in the night as opposed to waiting until they get into bed to worry. And we do add in some healthy sleep habits recommendations, especially in people who we see there's a specific problem behavior. I will say, when we look at sleep hygiene, I think of it like dental hygiene. It's going to keep you well if you're well. They're good habits, but if you have a cavity or need a root canal, you need to have an actual dental treatment. And if you have insomnia, you probably need an actual interventional treatment like CBT for insomnia to actually correct the problem, as opposed to just these healthy habits alone. There's some examples of that. People often ask me medications or CBTI. I say, well, they're not exclusionary. They can be combined together, but benefits of CBT would be that it's effective, it has few side effects, and is long lasting. Though it does require motivation and hard work, and compliance can be an issue. If we think of barriers, access, cost, people have to have motivation, compliance, and people worry about, there's some people there's still stigma about accessing therapy. I do think a lot of these are addressed with digital therapeutics because they often are at lower cost or publicly available. There's a lot of reminders about compliance, and it can be done from your own home or even with a virtual therapy. That's the case. People often ask me for tips to help people with their sleep. And, I know many of you are not trained or have never even heard of CBT for insomnia. I have some resources included if you want to learn or even develop proficiency in that therapy. But these are some practical tips for healthy sleep that I think it's safe to share with any individual. The first thing, stress-associated sleep disruption, medical event-associated sleep disruption are normal biological reactions to incident stress or change. We live with insomnia today because at some point in our evolutionary history, insomnia allowed us to survive. So the ability to suppress sleep during stress can be very helpful if you're a student cramming for a test or if you're someone who needs to do shift work. During this time period, we should promote healthy sleep practices to prevent conversion to chronic insomnia. But we should also recognize that sleep disruption is going to be a fact of life at certain points in our lives. My first sleep better rule would be waking up the same time every day, regardless of how many hours of sleep. And this includes weekends, because a big 2-hour shift in your Saturday or Sunday wake up time can make Monday and Tuesday very difficult. I recommend people get out of bed and get their body moving and get outside and get that light exposure within 30 minutes of waking up. My sleep better rule 2 would be to move worries and anxiety outside of the bed environment. If you worry in bed, it can make you conditioned to worry in bed, and it becomes the place where you start worrying every night when you go to sleep. So deal with worry and anxiety earlier in the evening, either in a journal or by talking to a friend, or devote time to problem solving or planning a couple hours before your bedtime. Like Dr. Corkum said, cell phones and light, it's not just the light. We probably overstate the impacts of light, even though there are impacts of light. I really think of it as that dopamine burst of social media, or that stress from getting, the concerning text message from your boss the night before. So those backlit devices have multiple impacts on our sleep. And I think that 60 to 90 minute, getting a shower, packing your lunch, those kinds of things can really help our body and mind wind down and get ready for sleep. And my sleep rule 4 would be not to spend time in bed trying to sleep. If you're in bed and it's been 15 minutes and you're not asleep yet, it's because your body and your mind aren't ready to sleep yet. So getting up for a little bit of time and doing other activities, something quiet, maybe like reading or a puzzle, until you feel that wave of sleepiness and going back to bed and trying again later. I've included a number of sleep health resources. This is more as a reference than to go through today. Some great websites here for just general sleep health information. Specifically, I think as social workers who do a lot of shift work at times, this Coping Better with Night Work resource is very helpful. It's a series of interactive web tutorials. This is a phenomenal resource that I share with a lot of patients. And I know as people who work with individuals with trauma, nightmares can be a big concern. I would never have thought such a simple technique could be so effective. And this is actually the first intervention I do with my patients who have recurrent nightmares right now. It's something called the dream completion technique. I will often watch the 6-minute YouTube videos in session with patients and kind of give some corrective coaching, give them a calendar to kind of check off that the nights they've done the exercise. There's actually an extended self-help version, an excellent resource for nightmares, which I know is something we haven't talked about today, but can be significantly disruptive. This can help people who have a formal diagnosis of PTSD or people who have non-traumatic nightmares alike. And Dr. Justin Havens is a psychologist, I believe, in the UK who created this video series, and it's fantastic. As far as accessing CBT for insomnia, it's available in a variety of formats, ranging from self-help to manualized group to brief individual sessions to even, working with someone who would be like a behavioral sleep expert. And each of these interventions has their pros and cons, and there's different people or different matches for this. And you don't necessarily have to go through these in an order, but pick the one that's, the best for the patient or the most accessible for the patient. Here's a couple workbooks that I really like. 2 Canadian authors, Dr. Judith Davidson and Dr. Colin Carney. I specifically find this is a great reading level. I actually use this Sink into Sleep in a group program that I run here in London. But also Dr. Carney's specifically has specific information for people with depression, anxiety, and chronic pain, which I think is also very helpful. Digital therapeutics, like I've said, can be consistently delivered, evidence-based, easily scaled, more cost-effective, and can be integrated well with in-person care. And they present an alternative to medication in the absence of a trained therapist. And I really think of it something that as a social worker, you might even be able to suggest or guide somebody to use. And they're particularly useful, obviously, for motivated patients. Here's some general resources. It's kind of more general information about CBTI or information to support people going through CBTI. There are online self-guided programs, which range from this, which is basically just a text-only program. Dr. Colin Shapiro's created the Sleep Ontario website, which has some brief videos. Better Nights, Better Days, which Dr. Corkum is the brainpower behind and is already spoken about the access to. There's also some paid programs, or if you're in Ontario, this program is currently covered by the Ontario government. I have not actually assessed these programs myself, and I can't speak to the exact approaches they take, but they're therapist-led programs, and some US-based programs as well that you can access from Canada. And really, individual CBTI is delivered by a variety of health professionals, ranging from behavioral sleep medicine certified experts, clinical psychologists, doctors, social workers, nurses, pharmacists, and there's even unlicensed practitioners who market themselves as sleep coaches providing this information. And if you wanted to find local providers, there's some registries. I will say that I don't think these encompass everybody who's trained in CBTI. I know in London there are pharmacists who are doing this work with family health teams, for instance. But there's also numerous training resources available if you yourself are interested in getting this training. I've got some listed here, and you can get those and read about them. There's also some very helpful, entry-level textbooks, and even, a deeper dive for people wanting to extend their proficiency. And that would be kind of the end of the presentation.
I knew there were going to be lots of questions because of the size of the turnout, but I just want to say to the audience, thank you, first of all, for your participation and your questions. I want to apologize in advance, just looking at the time, although the presenters did stick to the time perfectly. It's not their fault, just the number of questions you have, we will just not be able to get to them all. I have been trying to triage them and combine ones that are similar. I think I'm going to start broad and then get more specific as I go down the list, if I think that makes sense. And so I'll leave it to you, Doctors Earl and Corkum, to decide who takes what. But I think I'll start with one, just asking big picture. What causes circadian rhythm disorders?
Chris, do you want to?
Okay, sure.
Multifaceted.
Yeah. I will say circadian rhythm disorders are very much biologic. It's kind of the way we're wired. They tend to emerge. You can see different patterns in different people at different stages of life, but the ones that become consistent or more lifelong problems tend to emerge in our teenage or early 20s. Those are the people who you see, they have like this lifelong pattern. They're the way our brain is wired. Partially, we see slower reaction times of the brain to light with its generation of melatonin. And that being said, there's other factors in our lives. So if you're someone who did night work for 20 years, you've gotten into this rhythm of working at night, and that can be sustained not just through the biological processes, but also the social structures that you've set up. If you only socialize with your friends at a certain time, and you have no reason to get up early in the morning, that's also going to kind of further cement a biological predisposition.
Yeah, and I just add to that, like that biological shift during puberty is often a critical time where we see some of those changes that then become kind of lifelong problems.
That actually, my next question was going to be, why does sleep reduce as you age? But I think you just answered that. So I'll ask the sort of next one, where a number of people have asked a similar thing to this, which is it possible that some individuals simply require less sleep? The example of a client who has been waking up since around 3 a.m. since preschool. Is this just okay, or is this a chronic conditioned response?
Yeah, I'll start and you can add in, Chris. Yes, I think there's individual variability, but like not probably that much. Not like, 2 hours of sleep. Like we're probably talking, a smaller window. what I find with children, at least, is often these night awakenings, people start to see them as an early morning awakening, but it's really just a night awakening that they didn't go back to sleep from. And then things perpetuate that. So I'll often find that, oh, well, I let them get up and they play video games until I wake up. And then the child learns to wake up early because they want to play video games. And so I would like to see that treated as a night awakening and hopefully get a little more sleep. So yes, individual variability, but probably not that much variability. And I think particularly there's a lot of myths around that, especially with children with neurodevelopmental disorders. Oh, my child doesn't need to sleep as much as typically developing or neurotypical children. And the evidence wouldn't say that. It would say that they probably have similar sleep needs.
Mm-hmm. I would agree with all of that and add that in my patients with insomnia, I've often seen people going to bed early because they feel they need to catch up on sleep. So if you're going to bed at 8 or 9 p.m. and waking at 3 a.m., that's 6 hours of sleep. So, that's an adequate sleep interval. But maybe these people aren't exactly happy with the timing of their sleep. And it might be something they developed over insomnia rather than an underlying circadian tendency. So, through CBT for insomnia, when we adjust the bedtimes, I start by asking people, what time do you want to wake up in the morning? So if someone wants to wake up at 6 a.m. and they're sleeping 6 hours, we set the bedtime window at midnight to 6 a.m. And it's difficult to make that adjustment initially, but I look at when we assess sleep health, we assess not just the amount of time, but the timing of the sleep, and if people are satisfied with how that is working in the frame of their lives. It wouldn't just be about the times, it would be about like timing, regularity, if they feel satisfied in the morning. But if they're waking up at 3 a.m. after 7 hours of sleep, that sounds perfectly fine. Maybe the problem is shifting their time of their sleep as opposed to the actual amount.
Wow. I think we're going to enter now what I'm going to call the rapid fire section, where I just have a lot of specific questions. There were a lot of questions about melatonin. So is melatonin okay for kids occasionally? And is daily melatonin okay for adults? And I will also just package in here, how about Gravol? Is Gravol okay? We got lots of questions about that, as well as magnesium glycinate. A bunch of questions about those. So just
Dr.
let
Earl,
that all
I'll let you deal with that.
So some of these questions may have come in before I said my little bit. There is some evidence for melatonin in certain populations. I would recommend that use of it should be directed by your physician. And I really think what Dr. Corkum said about implementing behavioral recommendations before kind of relying on the pharmacotherapy, because there is no underlying chemical imbalance necessarily causing this sleep disruption. And usually the medications are just sedating away a behavioral pattern that is sustaining insomnia. Gravol, absolutely not. I don't condone its use for sleep. Gravol is actually Benadryl that has had an alerting agent added to it to make it less sedating. So it's like taking a Benadryl in a coffee. I also don't use antihistamines like Benadryl in my sleep, so for sleep practice either. But I would say Gravol is an absolutely not. It's not indicated, labeled, or recommended for sleep. And it literally is the same medication as Benadryl. Dimenhydrinate, which is Gravol, is actually diphenhydramine plus 8-chlorotheophylline, which is basically a caffeine derivative. So it's like having a Benadryl in a coffee, and it's associated with increased cardiotoxicity, deliriogenicity. It's hot badness.
Bad. It's got to be better ways than that.
I do remember once taking a lot of Gravol to try to sleep on a plane and feeling extremely strange. So that checks out. Okay, and I have one.
I think it's interesting. Melatonin, while we can get it, I think it suffers from inconsistency in its formulation as well. We don't know what's good and bad. And in other countries like the UK, it's a prescription. So, and there has been a fair amount of research, and while, it might have some benefits for some people, definitely it shouldn't be the first thing people go to.
Okay, good to know. Okay, this one is about substance use problems more generally, I think it'll be very applicable to lots of our audience because of the places that social workers work. So they are wondering, do you have a perspective on specific medications for clients in early recovery from substance use disorders? My understanding is that sleep difficulties are very common in withdrawal and early recovery. Yeah, that's the basis of it.
I would say, first and foremost is making sure withdrawal itself is appropriately managed. If you have an undertreated withdrawal, you are going to be more likely to have, patients may require a supervised withdrawal facility as opposed to, a DIY approach, something like that. But, even when there is substance use complicating the picture, our body still has a natural biological drive for sleep. And it's often about appropriate expectation setting. Very few people in the population are going to sleep for 12 hours. But if you're somebody who is avoiding your use of substance, you may be going to bed at 8 p.m. because that was your problem window for when you were using. And if you're going to bed at 8 p.m., you cannot expect to necessarily sleep until 8 a.m. Oftentimes seeking the bed environment to avoid something is not gonna have great payoff in the process. And kind of like I said, there are times it is normal to have sleep disruption. That acute insomnia perspective is oftentimes a time where people do prescribe sleeping pills. I'm not necessarily condoning their use because, especially in someone with a substance use disorder, there can be a proclivity to misuse those substances as well. And individual physicians have individual practices that I'm not necessarily here to dictate. But that short-term sleep disruption associated with a very clear biological cause is oftentimes a time where people will be initially prescribed sleeping pills. And my recommendation is to ensure that that doesn't extend beyond a reasonable window if it's being used, to avoid long-term difficulties with transferring your substance dependence to a different substance. And specifically, if it's a sedative or an opioid that people are withdrawing from, that risk is particularly high because these medications can get people high if crushed, diverted, or misused.
Dr. Corkum, did you want to add anything?
No,
okay.
Perfect.
I got lots of questions.
I guess the magnesium, someone wanted you to talk to that. I don't know the evidence for that. Do you?
Not consistent evidence. These substances and medications, there's no randomized control. There's few randomized trials and very little in the way of meta-analysis or systematic review. I wouldn't consider it to be particularly harmful. Like in all cases, I just talk about what else is going on with someone's sleep. I know magnesium is something that can often help patients with restless leg symptoms as well. So oftentimes there can be a dual benefit depending on the indication. But really at the end of the day, the treatment guidelines for insomnia say behavioral therapy above medication. So that'll be my recommendation as well.
Okay, I do know that I think both of our presenters have other meetings to get to at the top of the hour. And so I'm going to just say, this is a combination of a few questions, but if there was one thing that you could put into a social work curriculum about sleep, what would it be? And to you, Dr. Corkum, if you need to take off, you can just exit out of the browser and we can finish without you if you have to. But that would be the last question.
I mean, I personally think that Dr. Earl just said it, is that behavioral, it's the behavioral approaches that are effective. And, I when I was looking at the chat, you see a lot of like supplements and medications and really, that should be a last resort and should go to the behavioral stuff. So, first I'd like to see some sleep curriculum, period. A little bit about why sleep's, kind of what we just did would be lovely, just at least to alert people to the impact of sleep and just some of those nuances, like that sleep can mediate the relationship between, trauma and poor outcome. I think that is critical for social workers to understand. The value of sleeping well, I don't think can be underestimated.
Yeah, and I would just add, if I was going to put something in, the reason I picked out those 4 tips is because I think they are better than sleep hygiene, but still as easy to implement. Like that can be written on one sheet of paper and given to every person who's having a sleep difficulty, and it would be evidence-based as opposed to being a list of things, stop smoking. Great. That would be lovely if we could all just stop smoking tomorrow. That's not going to help my sleep tonight. It'll actually probably worsen my sleep tonight if somebody started to stop smoking that day. So I find sleep hygiene is impractical in a lot of frameworks, and focusing on what we reasonably can change and help. And, setting a consistent wake up time is something that we can implement for most, if not everybody. Whereas a lot of the things about bed environment, things like that, are not as amenable to change. So those 4 healthy sleep tips that I included are things I thought really could be practical suggestions for people in their practice on a daily basis.
To the audience, I'm really sorry if I didn't get your question. There were so many. We are going to have to do another session on sleep. Maybe we can convince these two. I'm not sure. But okay, the slide deck, if you can't get it through the handout section, it's not working for some folks. I also posted the link in the chat. The certificate of attendance will be emailed to you within a few hours after the conclusion of the presentation. The recording will be available tomorrow through the same link, but I'll post it on CSW's website. I have to thank these experts. These are 2 very busy academics, experts. It's the end of term as well, so I have to just say a huge thank you for the time today. The number of thanks coming through the chat, I think you can see it probably right now. Is there anything you'd like to say in conclusion? And if not, I will wrap up.
No, just really appreciate the opportunity to talk to everyone. Hope that, everybody found a little something that they can use in their practice, or even maybe in their personal life. Because I know, given the type of work you do, you may also have some sleep challenges at times. So I hope that it was informative for all of you.
Thank you.
All right. Thanks one more time, the audience, for your attention and your questions. And I hope to see you all next time. Take care.
Bye, everyone.